Thank you all so much for having me. I'm really excited to be here to talk about, the topic I chose to talk about was related to using just-in-time adaptive interventions, or I'll refer to them as JITAIs throughout the presentation, to optimize behavioral obesity treatments, or I'll also refer to them as lifestyle modification interventions. I kind of use those terms interchangeably. And before I jump into the interesting work, I just wanted to quickly say that I don't have any conflicts of interest to disclose, and I'd like to acknowledge my mentors listed here, who are now my collaborators, but I still consider them mentors in some capacity, and acknowledge some of the programming teams that I work with that make this work possible, and to acknowledge the funders of the research that I'll talk about today, which is NHLBI and NIDDK. So I'll start with a little bit of an intro of JITAIs and how they can, overall, the concept of how they can improve outcomes in behavioral obesity treatment. And overall, throughout this talk, the goal is to really highlight how the JITAI framework can be used to guide the way we use digital health to expand the knowledge and advance behavioral obesity treatment. So I'll be talking about an example of a JITAI that I did work to develop. And then I hope to expand and discuss how I use the framework to inspire these tangential research avenues and this overarching research agenda. And hopefully I'll have time to close with some final thoughts that have been brewing about equity considerations in digital health research, particularly with JITAIs. So just to level set, I have the definition of a JITAI up here on the slides. The goal of a JITAI is to be delivering support exactly or as precisely as in moments of need as we could get it. They accomplish this by ongoing monitoring of an individual's states and context and ongoing adaptation of the provision of support in a way that changes as the individual changes. So the goal is, deliver support in moments of need, as well as avoid delivering support when it is not needed or might be contraindicated. For these reasons, we typically see JITAIs in tandem with digital health tools, because digital health tools are perfect for this unobtrusive, near continuous assessment of a person and their context. And also typically it's with a person at all times. So whenever intervention is needed, we can possibly reach them. So in the context of lifestyle or behavioral interventions for higher body weight, I wanted to talk about how I consider JITAIs in the context of this work. So these types of interventions are based on the premise that higher body weight and relevant health behaviors related to weight can confer risk for chronic disease, and we know this through a ton of research. Lifestyle modification interventions or behavioral obesity treatments are focused on improving overall health by making gradual and sustainable changes in diet and exercise that typically produce a moderate degree of weight loss. So we're looking at somewhere on the order of 3 to 5% of one's starting body weight to confer those health benefits that we're talking about. And importantly, because these interventions primarily emphasize gradual and sustainable change in behaviors, they're still highly recommended and encouraged in conjunction with the increasingly popular anti-obesity medications. So while my work that I'll talk about today and my current work does not involve these types of medications, this behavioral work is still so relevant and so important, even in the context of this changing landscape. So for those who aren't familiar with lifestyle modification or behavioral obesity treatment, I like to present this diagram from Cardell and colleagues. They published this article in 2022. And it's a really beautiful article. It sort of discusses the difference and the overlap and the distinction between eating disorder care and behavioral obesity treatments. And the article helps to clarify that the lifestyle modification interventions that I'm talking about today are supervised, evidence-based treatments for obesity, where the goal is sustainable behavior change to improve health. And that's a really critical and important distinction from most self-directed diets or crash diets, which have the potential to contribute to disordered eating and overall poorer outcomes. So per this article and per decades of research, the mechanisms underlying these sustainable improvements in health outcomes are engagement in health behaviors. So you have behavior change strategies, meal planning, diet quality. So these are the behaviors that that my work and the work of a lot of others target in this area. We're not trying to get folks to be losing a large amount of weight very quickly using unsustainable methods. So how do, I think I have to go back. There we go. So how do JITAIs fit into this? So when we think about evidence-based lifestyle modification for weight management, we know it's been deemed effective in a wide array of settings and populations on average, but there is a ton of variability in who benefits from which treatments and why. We also know if you've just lived in this world or tried to change any type of behavior related to your health, particularly related to diet and exercise, it's really burdensome. And that could be one reason why our interventions aren't doing so great for everyone. So JITAIs can be really, really helpful in this regard because they can help patients track what matters and that they can be sure individuals are trying to apply the right skills at the right time. So that's the way that I sort of fit JITAIs into this work of lifestyle modification. So our goal, or my goal, is to develop a JITAI to improve outcomes in lifestyle modifications interventions. So that's the goal I'll talk about today, but what actually happened was that we did that and got many, many, many more research ideas. And I'll talk about this in the context of the conceptual framework of what a JITAI is, or the elements that make up a JITAI. So through this framework, starting with the left of the slide, you have a decision point. A decision point is a time at which a decision about whether or not an intervention should be delivered is made. At this decision point, you have collection of tailoring variables, which are different values that indicate states of opportunity to intervene, as well as states of availability or receptivity to receive an intervention. And then you have the potential intervention options you might be giving to someone at that particular point. And this is all tied together, the tailoring variables and intervention options, with something called decision rules. The decision rules are how do we decide which interventions to offer, to whom, and when. It kind of just links basically the tailoring variables and how we're using them as to the intervention options. And the entire goal of the system is to target a proximal outcome, which is this short-term measurable behavior experience that is essentially your mechanism. And that mechanism is what's underlying your overall health or mental health condition you want to treat, and that's your distal outcome. So in this case, our distal outcome would be weight management or weight loss or weight maintenance, however we might want to frame that. So sometimes JITAIs are best illustrated in terms of an example. So I'd like to talk about an example of using a JITAI in my own work that's now called Project Adapt. So the goal of this particular JITAI, right, and through that framework, you could see many different JITAIs being spawned to try to help with weight management or lifestyle intervention. But in this case, the goal of our JITAI was specifically focused on improving adherence to the recommended dietary guidelines that are given during lifestyle intervention. So why did we choose this? So dietary non-adherence, which I'll refer to here and throughout as lapses. Lapses are considered to be specific eating instances that are just not aligned with someone's dietary goals or the dietary recommendations given. Our prior research showed that lapses are pretty important. They're frequent. They happen 3 or 4 times a week on average over the course of lifestyle intervention or when someone's trying to lose weight. They're predicted by momentary context. So they're not just like these things that occur either randomly or statically. They occur as things like hunger, presence of food, different types of emotions rise and fall. And while they're normative to some degree and expected to happen, more lapses are associated with less weight loss outcomes or with less weight loss and lifestyle modification interventions. And some of my research shows that they can also accumulate into an excess of about 400 to 500 excess calories a week, which is how we think that that's actually impacting weight, is through excess calorie intake. So we wanted to see if we could try to do something about that. So the ADAPT app, which, by the way, I have under there like refined because this app has taken several iterations since its initial conceptualization and development in 2017. But regardless, the main functions have stayed the same, which is that it's designed to predict when lapses might happen and then deliver suggestions to someone to try to keep them on track before the lapse occurs. So the workflow starts with a check-in survey to ask about any potential lapses and several predictors of future lapse. So you see on the left here, it asks if you lapsed since the last survey. And on the right here, it asks about affect and fatigue and about like 17 other predictors, which we'll talk about in a second. And if we reference back to our framework, these surveys, which come about 6 times a day, are decision points, right? They're a point where we collect information, and we collect information about potential tailoring variables. So those are the predictors of whether lapse is going to happen. And that's when those things are collected. So how do we decide on our tailoring variables? It was a lot. So to make sense of what all of the different factors we know to that influence eating behavior, we tried to choose the fewest number possible. So we pulled data across 2 of our studies where we used ecological momentary assessment. So for non-EMA folks, this is just repeated daily surveys that an individual answers on their smartphone in their natural environment about what's going on around them and how they're feeling. We used EMA to try to understand what momentary factors are most predictive of lapses. And we started with 22 predictors, and we used variable selection through lasso regression to identify variables that were predictive of lapse likelihood for the majority, otherwise known as greater than like 40% of individuals in the sample. So we ran individual data to see like what variables were coming up as predictive. And unfortunately, this didn't whittle us down all that much. We actually only got 18 predictors that we felt confident using as tailoring variables. We did not feel confident eliminating more than that. So it just goes to show you how varied eating behavior is and how many things go into predicting eating. So each of these variables are what get asked about in that check-in survey in the ADAPT app. So each time a person enters that information, their responses are run through a machine learning algorithm that we actually developed to predict the likelihood of reporting a lapse in the subsequent 2 to 3 hours. So that's our decision rule in the framework, right? If an individual is deemed likely to lapse by the algorithm, then deliver intervention. And what I think is interesting about this and important to know is that we're not trying to predict lapse as it's happening. We're trying to predict what's going to happen or be reported on at the next EMA survey. And there's a couple of reasons for this, but one of the biggest ones is that, you know, when someone's literally in the middle of eating, we don't want to be interrupting them. We don't want to be saying, hey, this is the lapse, although sometimes people have requested that. We want to try to be predicting things in advance and give people enough time to potentially change the course of their day. So that's kind of why the decision rule is applied as it is. And I'd like to talk just a little bit about how we developed this initial algorithm. It was actually quite a small pilot study. So we conducted a study of about 12 participants. And what they did is they completed a lifestyle modification program. It was actually Weight Watchers at the time. And while they were in Weight Watchers doing the mobile program, and it was Weight Watchers at the time, they also completed EMA about lapses and any of the potential tailoring variables for about 6 weeks. And we had really good quality data, partially because of compensation and partially because it was only 12 people. So we were able to really be on them if they weren't completing their surveys. But we were fortunate to have really good quality data here. And what we did is we used a supervised classification learning algorithm to let the models learn relationships between the predictors and the outcomes using this already collected data. So what we did is we held out a subset. We held out the first 4 weeks of their EMA completion. and use that to build a series of models. And then we use the models to generate predictions on the remainder of the data. That's called the test set, right? And we compared what the model predicted would happen with the actual response. And in fact, what we ended up doing was we used ensemble methods. These actually combine the results of several different types of decision tree models to make a final prediction. And that's really useful when you care about predictive performance and you want to maximize robustness, which we really did. And what we did through that is we achieved an accuracy of 72%. We achieved a sensitivity, which is correct lapse predictions, of 70%, and we achieved a 72% specificity, which is, depending on your area, might be on the lower side, but for first-time behavioral work, it's pretty good. We also did a permutation test to show that the model was statistically meaningful and better than chance. It was also pragmatic. So some of these models can get pretty intense, and we need to be able to run it online very quickly in a given moment because it's going to be working in a JITAI. So we needed it to be pragmatic, and fortunately we got it there. Something else we also wanted to know from these data was how well different types of models performed on each individual in the data set. So we didn't want a model that would do really well for only a few people. We wanted the best as possible for as many people. And what we found here is that when a model was developed from the entire group and then tested on a completely new individual, so let's say like that new individual was just coming into the study and trying to use this algorithm to predict their lapses, that's the white dots here. You can tell that we had very poor sensitivity over here, and sometimes in some cases a very poor overall model. It's not sensitive enough, or it's not specific enough, or both. However, building separate models for each individual, which is the gray dots, also was really tough because each individual didn't accrue enough lapse cases to be able to model reliably over the course of the 4 weeks of training. So what we found is that the models did the best were these hybrid group individual models, where we were able to use the group data and then like 3 or 4 weeks of data from the individual to make sure that the predictions were adequate. And so this is actually what we used in the JITAI. So we were really happy we did this initial analysis on our decision rule data. So if our established algorithm predicts that likelihood for lapse is high, we offer brief suggestions to help individuals stay on track to try to prevent future lapse. And these interventions have taken some evolution, so I'll talk about what we're doing currently in a bit. But again, right, these are the intervention options designed to impact the likelihood of our proximal outcome. So when we first pulled it all together, we decided to pilot it in a single-arm trial just to make sure everything worked. This was called On Track at the time, and so we again paired it with the Weight Watchers mobile program. It was still then Weight Watchers, now WW. On average, we found things were going really well. Lapses were reduced, weight was reduced an amount that we would expect it to be, engagement was high, and the algorithm was performing well, and people were opening their alerts and they were accessing everything. But it didn't really get me what I really wanted to know. And what I really wanted to know was more about intervention efficacy in very specific moments. So I wanted to know if at any given moment was any intervention effective at preventing a lapse compared to no intervention at all. I know lapses are going down on average, but that could be for a bunch of different reasons. I wanted to know, are there specific theory-driven interventions that are better at preventing lapses? Do we even need theory-driven interventions? Can we just remind people, to stay on track and to stay alert? And more importantly, I wanted to refine our decision rule. Our decision rule was actually relatively simple. It's basically like, if someone's at risk, give them an intervention. Do we need to refine that at all? And fortunately, we received an R01 from NHLBI to answer these questions in a micro-randomized trial. So A micro-randomized trial is used for a treatment where its different components are focused on a proximal outcome that might be delivered numerous times a day or week. So it's not only for JITAIs, but it's primarily used in the context of trying to refine and understand the efficacy of JITAIs. The key feature of this design is repeated within subjects micro-randomization. That's opposed to randomizing someone once at the outset of a trial, or even in a SMART design, maybe randomizing them once, maybe twice or 2 or 3 times. And this repeated randomization is so critical. It makes these designs very efficient, and it's really like the source of your adaptation. So every time you randomize is essentially a chance to learn something about how or when to adapt your intervention. So that's what I applied in the case of Project Adapt. So for this trial, we actually built the MRT into the existing app framework. It worked really, really nicely. So the way that this goes is that we have a decision point, which is someone completes a check-in survey. Oops. Okay, got my clicking mixed up. And once they complete their check-in survey, we have tailoring variables. We have all of that information that goes into the machine learning algorithm. And the algorithm says, hey, based on these responses, someone's at risk or not at risk. If they're not at risk, we don't deliver any intervention at all. And if they are, we randomize them to an intervention option. And then we measure whether or not they reported a lapse at the next EMA survey. Oops. And this happens several times throughout the study. Someone basically after that, randomization, it just all happens again at the next decision point. So we found this mouse speed is double clicking on me. Okay, so we found through this that this results in typically about 89 randomizations per person in the trial. And we've got a target N of about 159. I think we exceeded that a little bit. We just wrapped data collection this month, which is very exciting. So what we ended up having these 159 people do is they did a 3-month online weight loss program. This was not Weight Watchers this time or WW. It was an online weight loss program that we run through our center. And they also did a 3-month weight loss maintenance period. And they used the JITAI that entire time with the MRT so that we could study the efficacy during active weight loss and during weight loss maintenance. And the interventions we tested here are essentially 4 different theory-driven interventions and 2 sort of like control conditions. So we have an education condition, self-efficacy, motivation, self-regulation, just a generic reminder that says, hey, the algorithm, the app thinks you're at risk. Just, try to stick with your plan for the day, and then no intervention at all. Which is actually the condition I'm most excited about. So what can we learn from this? Given the fact that we have not analyzed the data, here's what we're hoping to learn. So I'm hoping to learn which interventions had the greatest immediate proximal efficacy. I'm hoping to learn which interventions tend to work for whom and when, generally. So that's our optimization, right? So we can then say, in general, we can optimize the intervention to say, earlier in treatment, do this versus later in treatment. But, even an even more exciting avenue here is to see if we can actually better our decision rules through something like reinforcement learning, where instead of just optimizing and saying, here's a generic decision rule, maybe on what to do when risk is high, maybe we can start to personalize this. Maybe an algorithm can help us select the right type of intervention that's most likely to maximize success for any given individual. So that's the personalized nature of this. And we can do this all pretty efficiently. These are just the top 3 research questions we can ask for 160 people, but I think that we'll be doing lots of exploratory analysis for a long time, hopefully, using these data, and hopefully they'll spawn, additional research. Speaking of what we can learn, it's not just about bettering the JITAI. Because MRT is an experimental design, we can also be very strategic about designing the study so that we can learn something about theories of behavior change, right? So we're not just trying to say, here's the next JITAI. We're trying to move the field forward. So for instance, with ADAPT, we selected our interventions very carefully based on an existing model of adherence, a well-known information motivation strategy model. You might notice, and reviewers did too, that this model might look a little bit static. There's just a couple of arrows. There's very few double arrows or like arrows leading back to each other. And we noticed that too and thought maybe our data could help with that. So one way that we can think about updating this model is, for example, if we find that time in treatment is a moderator for whether or not educational or motivational suggestions have an effect on lapse, we can update the model to include time in treatment as a factor in this model. We might also find that moments of dietary adherence, of successful adherence, where a lapse doesn't happen but maybe could have or was predicted, might also improve motivation or improve education or improve knowledge. And so we might say, hey, these arrows actually go both ways here. So I'm not saying this is actually what happened yet, but my hope is that we can start updating these traditionally sort of like quote unquote static models. And that has potential to make an impact on the field beyond the development of just the JITAI. This has the potential to impact treatments related to adherence much more broadly than my single JITAI. So that's the hope. We'll stay tuned on the results there. But along the lines of making impact with JITAIs, I did want to shift gears to talk a little bit about the JITAI framework that inspired these additional research avenues. So I think a lot of optimization researchers can agree with this, that in the course of optimization, you tend to learn more than you bargained for. And I personally think the best way possible, but you know, to each their own. So let's return to our framework. While there are potentially 100 of different research questions you can ask with this framework, I do have limited time today, so I'm just going to focus on the two that felt more salient to me. I specifically, in the course of this work, honed in on the idea of the proximal outcome of lapses and adherence. You know, because as many people will tell you, without a rigorously defined and measured proximal outcome, a JITAI could very easily fail. Because we're not sure what we're intervening on, we're not sure how we're measuring it. It's a real pain point. So while I was researching lapses, I noticed a couple of things that really stuck out to me that I wanted to try to fix and understand more. So the first is that they were kind of hard to define. Defining a lapse is actually quite difficult. And the second was they're actually very hard to measure. So I'll talk about some research studies focused on those areas in particular. So the first one is that our definition of lapse is really difficult. Dietary non-adherence is really actually quite heterogeneous. And the solution that I came up with there is to try to study and accommodate that. So when we think about adherence in the context of other areas like medication or smoking cessation, the behavior of non-adherence is actually pretty clear. It's when the person engages in the behavior that you're asking them to not engage in, or when they're not engaging in the behavior you're asking them to engage in. But when we think about this in the context of eating behavior, it gets a little bit mucked up. So there's several behaviors that can actually encompass non-adherence. So someone could eat a bigger portion size than they've intended to. They could eat a specific food that they were trying to stay away from. They could eat at a time that was not planned. How many folks have maybe planned to have a larger eating episode or plan to lapse for a special occasion? Oh yeah, and you could do more than one of those things at a time. So because they're all different eating behaviors underlying a very broad construct, right? Because when we report on lapses, this is a part I left out, we aren't asking people, we're just essentially asking them to define it for themselves. So most often we're saying a lapse is any eating episode that you think is, might lessen the likelihood that you'll meet your weight loss goals or your weight maintenance goals. So we're very, very broad here and letting a lot of folks define that for themselves. And that's because lots of people have different dietary goals, so it makes sense for them to do that. But I did want to study these differences further. I had a feeling that these differences were really could be a problem. And what we did is we did a secondary analysis of data from one of the pilot studies that served as the pilot for the ADAPT app. And we had 121 people, and they all reported on different predictors of lapses. And they reported on the types of lapses. So they reported on whether or not they lapsed by eating too much or eating a specific food, et cetera. And they did that over 10 weeks. And what we found was a little bit not surprising, right? Only certain types of lapses were associated with weight loss during treatment. So this might mean that we could do better than targeting just any lapse, right? Maybe we should target certain types of behaviors that are lapses, which makes a lot more sense and is more reasonable than trying to prevent all lapses at once. Additionally, we used lasso regressions again to see which variables were most predictive of different types of lapses. And for time's sake, I didn't include all of the results here, but these are just two of the stability analyses. The x-axis here is the proportion of time that each variable on the left was selected as predictive of the specific non-adherence behaviors during resampling. And you can see that when individuals reported eating a larger portion than they intended to, this was predicted by hours of sleep, whether or not they lapsed before in the day, their hunger levels, alcohol intake, and that sort of line is where we make the cutoff as something as a reliable variable. Conversely, if someone's eating at an unplanned time, that's more predicted by urges to eat, cravings, time of day, tempting foods being around. And there are some also consistent predictors where hours of sleep and prior lapse are sort of consistent across the two. So that was just a pilot study, right? But those data are indicating to me that maybe behavioral, psychosocial, and contextual predictors of non-adherence might actually differ across different subtypes of lapse. Also, based on our research, we had a hunch that maybe these subtypes actually look different from person to person, right? So my version of a lapse might not be the same as someone else's version of a lapse, and might even change within persons over time. So my lapsing at the beginning of a treatment program might look really different from my lapsing at the end of a treatment program. So we proposed to try to study this systematically, and we got an R01 from NIDDK to study this. So I'll quickly describe an ongoing study here where our goal is to differentiate dietary lapse types and try to understand their impact on the outcomes that we care about in lifestyle modification, so weight and energy intake. So this is the FUEL program, got lots of great names for these studies. And what we're doing in the FUEL program is we're taking a behavioral phenotyping approach. So this is a precision medicine tool that improves upon a one-size-fits-all approach by revealing underlying behavioral patterns that might elucidate individual susceptibility to poor weight loss or engagement in lapses. And typical behavior, the thing that's different about this is that typical behavioral phenotyping studies tend to cluster people on unique and meaningful characteristics in terms of their individual. We're actually going to apply these principles to understand phenotypes of specific behaviors within individuals. So we're going to phenotype the lapses, not phenotype people as a type of lapser, because we don't think that exists. We think everybody engages in lots of different types of lapses. And we're going to accomplish this with a multimodal assessment protocol that includes EMA, so smartphone surveys, passive sensing of eating, which I'll actually talk about in a little bit, passive sensing of physical activity, sedentary behavior, and sleep, as well as geolocation. And folks in a online weight loss program will complete 5 14-day assessment batteries where they're using all of these tools over the course of 18 months. So we'll get nice little snapshots of folks as they're in treatment and then in a weight loss maintenance period. And while we're still actively collecting data, we're targeting about 150 people here. I wanted to sort of illustrate the very rough hope of what we'll get. So what you have here is my location data throughout the greater Providence area. And the red dots are the places where I traveled. And this is from a test of our EMA app. And so the hope is if we combine the EMA reports with location and sensor data, we're hoping that we can start to profile different types of lapses. So you see here, maybe like this location is associated with, lapse type 1, where there's a high density of food sources. I'm eating very quickly. I've had poor sleep the night before, and my mood is low. Or maybe this location is associated with lapse type 2. I'm at a restaurant here, and I'm socializing, and I had really high physical activity levels during the day. Or maybe we're looking at a lapse type number 3, where the important mechanisms there are driving distance to food, the fact that it's nighttime, the fact that I'm hungry. So the goal is to, help to identify these so that we can then actually start to try to tailor our intervention. So if we're able to do that in the current proposal, then we can hopefully inform future interventions that are targeted to specific lapse phenotypes that have the greatest impact on weight. And, we can think about this in a lot of different ways, but just to tie this back to the JITAI framework, we can also incorporate phenotyping to inform, maybe personalized proximal outcome, either intervention or assessment in the ADAPT JITAI. Maybe we want to refine to start predicting these phenotypes or intervening on these phenotypes instead of all lapses. So the work sort of dovetails nicely and hopefully will come together in a way that we can, better understand and better intervene on these behaviors among individuals who are in lifestyle intervention. So to pivot, the second problem I identified pretty early on, and is something you might have been thinking about throughout this entire presentation, is that lapses can only be measured via self-report. At present, at least. So this reduces sustainability of long-term measurement and intervention. And so it's a huge issue. A lot of folks that are doing work in the JITAI space, they'll be working on physical activity or sedentary behavior or even sleep. And these are all things that could be very easily passively measured. Eating is not one of those things. And so that's something that's really important. So another area for me was thinking, how can we use more objective measures of eating to help further our understanding of eating behavior and enhance JITAIs? So to try to solve this problem, I partnered with Dr. Adam Hoover at Clemson University to apply his technology for wrist-worn detection of eating. He's actually found over a decade of research that the wrist roll motion of food being brought to the mouth, or drink being brought to the mouth too, can be reliably analyzed using deep learning to detect when someone is eating and to help characterize it. So this gets us passive information on the number of bites someone's taking, the duration of eating, how quickly they're eating. And I received, to transition out of grad school, I received an NHLBI F32 that sought to use this method to study how we can use this objective measure to understand more about dietary non-adherence and maybe even come up with an objective measure of dietary non-adherence as individuals were participating in a lifestyle modification program. So in this study, individuals underwent a 6-month program and completed EMA every other week to report on their eating, on their lapses, et cetera. And they also wore continuously wore a research grade accelerometer called an actigraph. And the actigraph is critical because it collects what's called IMU, inertial measurement unit, which is essentially 9-axis of wrist roll motion, which is critical for detecting eating. So we can't do it with like a Fitbit or anything like that. So what we found, just a little bit to show you the promise of this, is we matched up the objective eating data from the actigraph to all eating episodes reported via EMA and conducted an analysis to see if objective eating characteristics could distinguish momentary lapses from other eating episodes. And what we found was really interesting. This is just an example, right? But we found generally that eating episodes were more likely to be lapses when they were less bites and slower. So think about this in terms of like grazing maybe, or more bites and faster. Think about this as like you're eating something really delicious and you're eating it pretty quickly. So there wasn't just one type of lapse in this data set, right? And so that initial study sort of gave me greater confidence that lapses can take various subtypes, right? Which we'll find out more about in the FUEL program, the previous study I mentioned. But it also brought me into the world of passive detection and characterization of eating, which is notoriously difficult, but simultaneously extremely important for JITAIs that target eating. I've had this conversation with many folks previously that like until we can get good, reliable, in the moment, passive or nearly passive measures of eating, JITAIs related to eating behavior will suffer, right? So I learned that the field of passive sensing of eating is definitely blossoming and wonderful, but it's also struggling with generalizability, right? Eating is not the same for everyone. Context mattering. Eating doesn't occur in a vacuum, but we often attempt to try to measure it in one, right? Because we're trying to control as many variables as possible. And there's not like a great form factor. There's folks that do wearable cameras. There's folks that do glasses cameras. We're using the watch, and even with the watch, people don't want to wear it on their dominant hand, right? So we need to try to find devices, or as many devices as possible, that folks are willing to wear that we can trust. And this is sort of what inspired the next study that I put in with Dr. Hoover that was funded by NIDDK to really focus on this validation of detection of eating and free living. And really the goal here is to see if we can actually learn to estimate energy intake from bites and sips with just very minimal user input. And the third goal, which is really important, I think, is related to trying to get this all working in a smart ring as well as a smartwatch. And what you see here is one of our RAs using our smartwatch and smart ring in our app prototype. The smart ring is a little clunky, but we're hoping that in future work we'll be able to work with a company that will have a better form factor for that. Specifically what we're going to do, what we're actively doing right now is we're training in 2 semi-controlled settings from the cafeteria and the home, and then we're seeing how well the devices work during free living. So this is something that's super important, right? This idea of taking what's happening in the lab or in a controlled setting to see what's going on out in the world. So we're really excited to have both of those data in one setting. And, to sort of, again, bring this back, right, this can really help with my research and research like it, because this can lead to improved lapse characterization. It can lead to improved lapse detection. But more importantly, I hope that this can lead to other proximal outcomes for JITAIs targeting eating behaviors. So maybe this can lead to targets of rate of eating, or missed meals or snacks, or duration of eating episodes, or some other facet related to eating that I haven't even thought of yet. So I think these types of measurement opportunities just really open up our world. And it's been so exciting to collaborate with an engineer who's very focused on the measurement side as someone who's very focused with an eye towards the intervention side to think about all the applications of this. So one way that we're applying this already is and I don't have time to talk about it much today, but we're already starting to apply it in the context of like, can we use this type of wearable eating tracking to help with self-monitoring in behavioral obesity treatment or in lifestyle modification? So there's a lot more to come here, and I'm very excited about that. Before we close for today, though, I did want to chat just a little bit about JITAIs and say a word about how JITAIs and in general digital health works in the context of high risk, high reward innovation. So one of the major risks that we've all come across in the area of digital health, and particularly in the development of optimized interventions and optimized digital health tools like smart rings and smartwatches, is that these tools run the risk of inadvertently exacerbating health disparities if they're not carefully developed with the many groups who stand to benefit from them in mind. And in general, we need better science on the integration of JITAIs and JITAI-like tools in practice and in communities. I've been talking to a lot of folks about trying to integrate this more thoroughly into proposals. I certainly don't have all the answers, and I think it's just something I've been noticing as a pitfall in my current work. And so I'm hoping as we continue to evolve, these tools and these practices, we can start to better work together on this stuff. I did recently collaborate with a team of experts in health equity, community engagement, and implementation science to author a position paper in psychosomatic medicine where we attempted to outline ways in which digital innovation can support and be driven by social determinants of health framework. So again, always going back to a framework. We love a good framework. And in doing so, we can really create a roadmap to trying to narrow the digital divide while also advancing innovation and reducing disparities by developing digital tools that are truly accessible and able to be implemented among a wide range of groups. And so the argument here is that innovation doesn't always lie in the next big, like, I'm going to use this next big algorithm, I'm going to use this next tool, but innovation might lie in the creative application and implementation of digital tools that we have to be helping groups that are historically underrepresented or underserved. So the paper discusses 3 major initiatives that's born from this conceptual framework, but I'll just sort of focus on just one, which is related to JITAIs. But a major push has been developing tools for the prevention and treatment of chronic disease that tackle structural and social determinants of health, right? So when we think about digital assessment and predictive analytics, we tend to sort of live in this like intermediate determinants of health, intermediary determinants of health here in the behavioral and biologic and psychosocial factors. But future work could really focus on implementing digital assessment and predictive analytics through exciting partnerships between researchers, healthcare decision makers, policy members, policymakers, community members, and things like that. For example, stakeholders could utilize the above mentioned, wearables, smartphone surveys, algorithms, et cetera, to inform data-based intervention at the community or the policy levels. So can we expand these principles beyond in-the-moment intervention and create this sort of like bigger picture just-in-time framework focused on allocation of resources to the most in need? Is there a way we can sort of like titrate up that in-the-moment idea? Or that just-in-time idea. And similarly, even if you don't titrate those up, JITAIs themselves can provide intervention that's adapted to or directly targeting social determinants of health. Like, for example, a micro-randomized trial or a JITAI could target physical activity considering someone's location data. And concerns about neighborhood safety to suggest appropriate exercise options. That's just one like very, very generic example. So the idea here is that like, can we work on embedding all of these frameworks to create something that is like accessible and a different type of innovation that some of us have been thinking about, but many others have. So finally, I'll close so that we can do some Q&A, but if anyone is interested in the work that I spoke about today, I wanted to very, very quickly plug our T32 postdoctoral fellowship, which is recruiting. The postdoctoral fellowship is in cardiovascular behavioral medicine at Brown, and Dr. Graham Thomas and I are both taking applicants for postdoctoral fellows who are focused on using digital health tools to understand and intervene on health behaviors that are implicated in CVD risk. So we're really interested in folks who are hoping to partner on research like this or new research that's tangentially related to this. As I mentioned, the framework is very inspiring in terms of research ideas. So if folks are interested, definitely check us out. And I will go ahead and end there with some references and a thank you so much.
Thank you very much. Terrific presentation. I am going to open it up to the audience. Maybe I should lead with the first question I had is how do you balance the frequency of JITAI interventions to prevent user fatigue while maintaining effective behavioral support?
That's a great question. And I think every JITAI is different. So some folks will have like a intervention limit and will say essentially once a user gets a number of interventions per day or per week. Fortunately, our decision rule algorithm of identifying risk shows that we generally are giving interventions or predicting risk on average once per day. And so we deemed that to be pretty tolerable as far as if someone gets an intervention once per day, that seems to work for them. So we sort of balanced it through rigorous testing. That's where the pilot data really, really helped us out. But you know, in reviewing the logs, folks sometimes got more than that. Sometimes folks got 2 or 3 of them. And so we try to keep them really brief to make sure if they get a couple of them that it won't be too burdensome. But you know, for different health behaviors, that might range in tolerability. So that's like a population consideration. I think it depends on who you're studying and what you're intervening on for each individual.
See. Oh, interesting.
Yeah.
Let's see. Audience, have any questions?
We do have a question from the chat, and it was, hi, was the prediction model trained using the data across subjects?
Yeah, that's a good question. So the prediction model was trained using about, we started it off, the initial model was trained with about 12 people. And essentially what we did is we wanted to train the model so that it acted or it got data in the same way that a JITAI would be receiving data. So sometimes when you train a prediction model, you hold out like a random subset of data, but we didn't want to do that because we knew that like time was an important factor. And so what we did is we held out the first 4 weeks of data, and then we tested the model on the final 2 weeks of data. And we did that at the group level. So we just did everybody's first 4 weeks of data, trained and tested it on everybody's last 2 weeks of data. And then we started trying to play around with mixing and matching. So we did that just individually. So we've done just all individuals with their own data, which went pretty poorly. And then we did a combination. So everybody's prediction model has data from the entire group in the model. And that actually gives it strength, I think, and robustness, because otherwise there's risk. If you just do it for an individual, there's risk for overfitting. And there's also risk for the model not really learning very quickly. Like it could take 6 or 7 weeks for it to start to learn because individuals only lapse 3 or 4 times a week at most, and sometimes even fewer. So hopefully that answered your question. But if it didn't, feel free to ask a follow-up question in the chat. I also see a hand raised. Yeah.
That's me. Great presentation. Thank you. My question was actually about the EMAs. Just to clarify that I understood that in data collection, each EMA was testing those top 18 aspects. So it had 18 questions plus, of course, the time of day as a timestamp. And that was presented 9 times a day. That seems like a lot. Sort of.
It is a lot.
I'm curious.
It was presented 6 times a day,
Oh,
so
6
that's
times.
slightly better, but still a lot. And we actually did, so one of the pilot studies we did was an RCT where we actually tested. So one of the things I find that's most interesting about the transition from just EMA to EMA in the context of a JITAI or EMI is that sometimes you have to sort of like test the belief about what's important in an EMA study versus what's important in a JITAI. So previously, right, we were like, burden can't be too high. People have to complete as much as possible of these. And so what we did is we actually administered a random subset of 8 of the 17 or 22 predictors at a time, so that people were only answering like 8 or 9 questions at a time. But the problem is that introduces some systematic missingness into our prediction algorithm. So I actually did an RCT to say if people got the short version of just 8 questions or the long version with all 17 questions, what will happen? Will the compliance be meaningfully different? Will the algorithm do better? And what we found is that the compliance was lower. So we had overall less surveys completed, but the algorithm did so much better because the data were complete. So every time it got data. So it didn't matter that we didn't have great compliance, the algorithm was doing much better. So we sort of decided like that's what we wanted to prioritize. And gets tied in with why we need to get passive sensing in here to help measure lapses and whatnot, because of course lower compliance is not what we want for reporting on our proximal outcome. But it was an interesting question that we were like, oh, actually let's test this assumption about what people can handle and what's important. Overall, we really need to reduce the burden of this strategy, though. It is quite burdensome. So in the future, I'll be looking for more advanced algorithms to maybe personalize to each person what gets asked about, because not every predictor is important for every person. So that maybe there's fewer of them. Maybe we can start to personalize when check-in surveys come, so there doesn't have to be 6 of them. I think there's a lot of room for improvement.
Thank you.
We have an
Vivek,
additional. Oh, I was going to say,
Oh,
we have an
sorry.
additional chat question. How do we preserve the intrinsic value of behavioral modification when pharma options promise faster results?
Yeah, just hitting me with the hard-hitting questions here with 1 minute left. I think the answer is that, it's the very short answer is that we need more behavioral scientists and behavioral interventionists to be involved in this research with pharmaceutical solutions. So what we know so far about the way that these types of solutions interact with people's behavior and long-term sustainability is very poor. We don't know a lot. What we know is that behavior change is important no matter what. And that sometimes these medications can grease the wheels for behavior change in a way that's really, really helpful for a lot of people. But there's a lot of really cool articles about this idea of intentionally working with behavioral interventionists to work on like titrating off medications and also maybe titrating back on them at certain times. So this is like a huge area of research. And I think preserving the intrinsic value is mostly just highlighting like, yes, the medication helped, but it helped you because you changed your behaviors, and that doesn't go away. The behavior change is still quite important. So that is a very broad take on a very important question that we should continue to explore in future webinars for sure.
Having said that, Stephanie, thank you. This so many intriguing questions, and we would love to have you back. I want to
Awesome.
thank all the audience out there. I see many familiar faces. And Stephanie, thank you. And thank you all for joining today's webinar. We'll be